3 injections. Everyone worked. The first bought you 4 months, the second 3, the third 6 weeks, and then the knee was grinding on the stairs again. Nothing failed. The needle went exactly where it was supposed to go. The pain returned anyway, because what generates it was never on the fluoroscope, and never the target of the procedure. I am Dr. Padda, an interventional pain physician in St. Louis. This is the closing video of the series, and the one where I am hardest on my own specialty. Nobody in a high-volume pain practice is paid to ask why the same knee regenerates the same signal every 90 days. The block is a billable event. The question is not. So you come back, the interval shortens, and after 2 years, you have a thick chart and the same stairs. Now I am going to turn on the people who look like my allies, because you are being sold a mirror image of the same problem. A diet, a stack of supplements, a red light panel, a promise that inflammation is the root of everything. Both models sell certainty. Neither shows you the grading behind it. I'm putting each part of my own 4-part architecture under a light, using 4 words: core, adjunctive, emerging, and untested. One of those words applies to something I sell. Understand the boundary. Everything I cite covers knee and hip osteoarthritis and non-specific low back pain past 12 weeks. Nothing else. Do not let anyone, including me, stretch it. A genicular nerve block deposits anesthetic on the articular branches, leaving the knee capsule, at periosteal landmarks, where the femoral shaft meets the condyles for the superior medial and superior lateral branches, at the tibial metaphysis for the inferior medial branch, under fluoroscopy or high-resolution ultrasound. A lumbar facet block anesthetizes the medial branches of the dorsal rami at the superior articular process. Both interrupt a wire. Neither changes load, and neither changes the chemistry the joint sits in. Excess body mass raises compressive load across a degenerating knee with every step. Adipose tissue is not inert padding. It sustains low-grade systemic inflammation, and elevated glucose slows repair. I silence the wire while the generator runs. Diagnosis first. Hip osteoarthritis refers to the knee, so I test hip internal rotation first. Crystal disease and inflammatory arthritis need labs and, if the joint is effused, aspiration, not an ablation. Back pain is nonspecific only after fever, progressive weakness, saddle numbness, bowel or bladder change, and unexplained weight loss are excluded. Pillar 1 is the precision interventional procedure, and I will grade it the way I grade everything else. Its established value is diagnostic. Done correctly, it tells me which structure is generating the signal. Its therapeutic value is real but time-limited, and the durability data are thinner. I will not hand my own pillar a grade I would refuse from a supplement company. A diagnostic block that reproduces and then abolishes your pain is evidence, not proof, that the nerve I targeted carries the signal. A single block is wrong somewhere between 1/5 and 1/3 of the time. So before I burn anything, I repeat it with a second anesthetic of a different duration, and I require your relief to track the drug. If it does not track, the block was a false positive, and the honest move is to stop, not to ablate. Now the risks, plainly: bleeding, infection, nerve injury, epidural hematoma or abscess, dural puncture, headache. In 2014, the Food and Drug Administration issued a drug safety communication on epidural corticosteroid injection. Rare catastrophic neurologic events including spinal cord infarction, paralysis, stroke, vision loss, death, that use is off-label. After ablation, neuritis, dysesthesia, transient numbness or weakness, burns. Corticosteroid raises blood sugar for days in diabetes. Repeated dosing carries adrenal suppression, bone loss, and inside the knee, a signal of cartilage loss without benefit. Pillar 2 is exercise and weight reduction. The 2019 American College of Rheumatology and Arthritis Foundation guideline by Kolasinski and colleagues in arthritis care and research strongly recommends exercise for knee and hip osteoarthritis in everyone and weight loss for patients who are overweight or obese. For them, it is not an add-on. It is core therapy, and the procedure is the add-on. The IDEA trial, Messier and colleagues in JAMA in 2013, randomized 454 adults, 55 and older, body mass index 27 to 41, with radiographic knee osteoarthritis. At 18 months, the intensive diet and exercise arm had lost 11.4% of body weight, with knee pain of 3.6 on a 20-point WOMAC scale. Exercise alone lost 2% and reported 4.7, a gap of 1.1 points out of 20, at or below a minimally important difference. That number came from knees on X-ray. The guideline covers the hip too, but IDEA enrolled no hips, so for the hip I have a strong recommendation and no number of my own. The benefit was measured at 12 to 18 months while the program ran. Whether it holds afterward has never been tested. Adherence is the treatment, not a detail attached to it. So this is for the people in that trial, or for adults whose nonspecific low back pain has passed 12 weeks with red flags excluded. IDEA's diet was low-fat calorie restriction, not ketogenic. A ketogenic approach is adjunctive, untested here, and demands supervision. Hypoglycemia on insulin or a sulfonylurea, euglycemic ketoacidosis with an SGLT2 inhibitor, a rise in LDL. Pillar 3 holds two things that do not deserve the same grade. Specialized pro-resolving mediators from omega-3 fatty acids are biologically fascinating. The human outcome data are not there. That is emerging. Worse for me, the same guideline that strongly recommends weight loss conditionally recommends against fish oil, the closest graded analog we have. They are sold without pre-market review and raise bleeding risk on an anticoagulant or antiplatelet. So disclose every supplement before a needle goes near your spine. The light is not emerging at all. Red and near infrared at 660 to 850 nanometers is cleared only for temporary relief of minor muscle and joint pain and stiffness, not as a chronic pain protocol. Pillar 4 is structured rehabilitation, and I have to be exact about what was tested. The Cochrane review by Camper and colleagues in 2014 included 41 randomized trials and 6,858 participants with nonspecific chronic low back pain. What it tested was multidisciplinary biopsychosocial rehabilitation, physical reconditioning delivered with psychological and social or occupational components by clinicians from different disciplines, not a posture class, not a home exercise sheet. In the 16 trials against usual care, long-term pain improvement was a standardized mean difference of 0.21 on moderate to low quality evidence. Now the sentence no one selling a protocol says out loud. Every one of those figures came from studies with no injection in the design. No trial has compared a procedure plus metabolic care against the procedure alone. The rationale is mechanistic, reasonable, and unproven. If anyone tells you it is established, they are selling. What I'm about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. Late 50s, radiographic knee osteoarthritis, body mass index in the mid-30s, low back pain past a year, an A1C in the pre-diabetic range, 4 prior injections elsewhere, 2 diagnostic genicular blocks, anesthetics of different duration, agreed the knee capsule was a genuine pain generator, and that bought a working window. Inside that window, the hard part began, and it was not the needle. 18 months of supervised weight reduction and progressive loading with a physician watching the medications. Weight came down near 10%, and it took 11 months. 2 long plateaus, 1 full regression over a holiday season. Pain did not vanish. It moved from constant to situational. Stairs stopped being an event. The interval between procedures lengthened instead of shortening. Hold that sentence loosely. I just told you no trial has tested this combination, and I will not smuggle the claim back in through a story. It is not what I can promise you. What I can say is narrower, not resolution. A generator running quieter, a wire that stays quiet longer for reasons I cannot yet prove, and a person no longer organizing a calendar around the next injection. If your procedures worked and then stopped, the next question is not which injection comes next. Ask which part of your plan is core, which is adjunctive, and which is a hypothesis. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Educational information, not medical advice. Individual results vary. That closes the series. Bring your questions and your skepticism, especially about anyone who has run out of it. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.